Welcome to everyone, and thank you for joining us for the first webinar in our series on global challenges and the COVID vaccine. It is 8 a.m. here in Durham, North Carolina, and I want to thank those of you in the US who have started your day early to join us. And I'm gratified to see that we have attendees joining from around the world. We want these webinars to be global conversations, so good morning, good afternoon, and good evening to you wherever you are, and thank you for taking time to be part of this important conversation. I'm Dennis Clements, the Interim Director of the Duke Global Health Institute, and it's my pleasure to kick off this series. DGHI is home to many researchers who have been working tirelessly on issues related to COVID-19. Our experts have spent the past 10 months producing timely research and analysis on all aspects of this pandemic, from prevention strategies to novel diagnostics and treatments, and to vaccine development and distribution. And we are delighted to offer this series as a forum to share this knowledge. But this series is not just about sharing what we know. We have invited some of the leading experts from around the world to share their work and what they are seeing on the ground as countries begin their vaccine campaigns. It's our intention that this series will be an informative and thought-provoking forum to explore the key challenges around this unprecedented global vaccination campaign. We will be offering this series on the third Tuesday of each month through May, so please join us for our upcoming discussions. Our next session will be February 23rd, and will focus on vaccine confidence and hesitancy. Watch your email for registration details or go to DGHI website at www.globalhealth.duke.edu and click on events. And now I'd like to introduce Udaya Krishna Udaya, the founding director of Duke's Global Health Innovation Center, who will moderate today's session. Thanks again for joining us, and Krishna, take it away.
Thank you, Dennis, and good morning, good afternoon, and good evening to all of you that are joining us today. Special thanks to all of our speakers and panelists who are joining us from around the world. As Dennis noted, the health and economic impact from the COVID-19 global pandemic is the defining moment in our generation, and we have much progress to be made. We're going to focus this series and certainly today's conversation around the race for global equity with vaccines and vaccinations. As Dr. Tedros, the Director General of the World Health Organization, put it bluntly yesterday, the world is on the brink of catastrophic moral failure. So we're going to try to unpack that by hearing perspectives from around the world, from experts and policymakers from Latin America, from Asia, from Africa, as well as leading experts here at Duke University. To get us started, I'd like to call on my colleague, Andrea Taylor, who has led research through the Launch and Scale Speedometer as part of our Global Health Innovation Center, looking at what's happening in terms of purchases of and distribution of vaccines around the world. So Andrea, welcome, and please give us a perspective on what you're seeing in terms of vaccines.
Thank you, Krishna. Sorry, I was muted. So just to set quick context, this is the latest data pulled this morning from the Johns Hopkins COVID tracker and shows the burden of disease for COVID-19 globally across the world. And so we can see that there's a very large burden of disease clustering in the US, across Europe, parts of South America, and also in India, as well as other parts of the world. And as COVID-19 deaths have now passed 2 million globally, a lot of countries and a lot of populations are really focusing on vaccines as a possible way to end the pandemic. So what we have done is collected publicly available data on vaccine purchases globally, really to track the flow of deals as they started early this summer. Before vaccines were even on the market, we saw an unprecedented number of advanced market purchases. We wanted to track those deals and understand which vaccines were being purchased by which countries and the numbers involved, and really understand some of the nuances around those deals and what they meant globally, especially for global equity. So I'm going to present some of our data now and to understand kind of the state of affairs with vaccinations, or vaccine purchases rather. And our data is updated every week on our website. At the end of the presentation, I'll provide that website. So you can go on and also see additional data visualizations and analysis that we put up every week. Just to really quickly kind of look at the top findings from our data analysis, we can see that more than 7 billion vaccine doses have already been purchased globally to date of the COVID-19 vaccines. And the lion's share of those have gone to high-income countries. So while high-income countries represent only 16% of the world's population, they currently hold 60% of the vaccines for COVID-19 that have been purchased so far. We can also see in this graph that middle-income and low-income countries are in trouble. So middle-income countries have a much smaller share of the vaccines that have been purchased so far. And lower income countries, actually, we just saw the very first purchase for low income countries come through last week, which was a purchase through the African Union and Africa CDC's Whole Africa approach. And so that's the very first time this week that we've seen that bar on the graph at all. We can see that there is clearly a very large gap developing and that's been holding over the last few months. So looking quickly at kind of vaccine purchases by sheer numbers by country, the blue bars are confirmed final purchases. So these are purchases that have been signed and finalized. The gray bars are potential, which may include purchases that are currently under negotiation or also options that are part of existing deals. We can see just by sheer numbers that the EU has purchased in final purchases, the largest number of vaccines, followed by the US and COVAX. And if we look at potential purchases, so these are purchases under negotiation, purchases that are options, we can see that, again, the US, the EU, and COVAX are at the forefront. But India is also a really interesting story. I just want to mention quickly here. India has a very large share of potential in the gray there, and that's through their manufacturing deals through the Serum Institute of India, because the Serum Institute has pledged that half of whatever they manufacture will be made available to the Indian market, will be reserved for India. So we are starting to see the Indian government has made its first purchase of some of those reserved doses in the past week. We're starting to see those vaccines start to roll out. So more of that gray will become blue over the next few weeks, we expect. So this looks at advanced purchases relative to population coverage and COVID burden. So we can see the countries. So for example, you can see Canada right there at the top of this chart, and Canada is essentially defining the top bound of this chart because they have purchased enough vaccines to cover more than 5 times their population. But we see that most high-income countries have more than 100% coverage, so they can cover their full populations, and some of them several times over. And again, we see that middle income and lower middle income countries on this chart, many of them are appearing on the chart, but are not at 100% coverage. And so there are very significant gaps in population coverage that we can see on this chart. And we're particularly concerned then about the countries that are facing high COVID burdens, but also aren't anywhere near 100% population coverage for vaccines. I think it's important to note with this chart that in the context of limited manufacturing capacity globally, the advanced market commitments that were made by the high-income countries early on and are still being made, while they make sense from the perspective of individual countries, they are also taking manufacturing slots off the market and leaving fewer available for middle-income countries and low-income countries that are now trying to make purchases and finding that it's much, much more difficult. There are fewer purchases to be made. And many of the purchases that they're making now, those vaccines won't actually be available for delivery until much later. So just wanted to really quickly mention COVAX. I think this will be discussed in more detail later in this webinar, but want to quickly note that it is the only global mechanism we currently have to ensure equitable supply of vaccines. And we know that the health and economic outcomes globally are better if we can vaccinate populations equitably across the globe. So every population in every country at the same time, on the same time scale, it leads to better outcomes for all countries, regardless of whether they're wealthy or poor. And we also know from tracking advanced purchases that COVAX has 1 billion doses in confirmed purchases and nearly another billion in options that they can exercise. And we've done some analysis of what we are estimating will be available to them in 2021. I should note that this is different than their estimation of what they think they will be able to deliver in 2021. So, but this is based on the manufacturing data that we have access to. This is our best guess. So with that, I will turn it back over to Krishna. Just want to quickly note, this is the website. It's launchandscalefaster.org/COVID-19. And we update our data weekly and provide weekly analysis of the major themes that we are seeing throughout the week on the website.
Fantastic. Thank you very much, Andrea, for covering a lot of material in a brief period of time. With that context of what's happening in terms of purchases, both advanced and now real purchases and deliveries of vaccines, let's get a better understanding of what's actually happening on the ground, especially from a low and middle income country perspective. One reminder to everyone that's joining us today, if you have any questions for the panelists as we go, please use the Q&A button at the bottom of your screen to submit those, and we will get to as many as possible as we go throughout the day. If you have any technical issues, please put that into the chat function and we'll try to deal with those offline as well. So let's dive in, and we're going to get perspectives from multiple continents, but also from various perspectives at the subnational, national, as well as regional perspectives today. And I'm privileged to introduce to you Dr. Patricia Garcia, who's both a professor at Cayetano Heredia University in Peru, as well as a former Minister of Health in Peru. We've seen reports of the challenges that Latin America has had, and certainly Peru, in terms of the burden of disease and the response. So Dr. Garcia, thank you for joining us, and please share the perspective of what you're seeing there.
Thank you so much for the invitation and for taking this very important topic into discussion. So first of all, in my 5 minutes, I would like to give you a context of Peru first, and then go into the pandemic and the vaccine, okay? So Peru is a very diverse country with 32 million people, with a very stable economic situation in the past years, actually, that allowed us to have a cushion of money, really, that made us feel more comfortable in front of the pandemic. However, between 2017 and 2020, we have been going through a political crisis and instability with a Congress, because of the opposition of the Congress to the president policies. It has been so unbelievably complicated that the president was replaced by his vice president in March of 2018, and the Congress was dissolved in 2019. And we had new elections of a Congress just at the beginning of January 2020. So you can imagine, just with the pandemic, we had a new president, a new Congress, and this political instability resulted in the change of 9 ministers of health, okay, and 4 different presidents in a matter of couple of years. I mean, I have been one of the ministers of health in this during this political crisis, and actually I tripled the average time of ministers of health, and I stayed for 1 year and 2 months. So Peru began its pandemic response preparations early in general, aware of the weaknesses of the fragmented and under-budgeted health system, aware of the social issues that we had, in which, in our minds, social distancing, for example, is something that is very complicated in general for Latin America, knowing that we had so many social differences with lack of water, problems of overcrowding, and also because of the political instability. However, having said that, I mean, we started early with lockdowns, etc., but things didn't go well. Important decisions, logistical issues, buying supplies, buying tests, everything was delayed, not because of the lack of funding, but because of the lack of stability. So regarding the negotiations with the vaccine, I am a member of the advisory board for CEPI. So I knew about CEPI, I knew what was going on. And although I was also called to be an advisor of the government on issues that had to do with innovations, and I have been the chair of this commission, we were making recommendations to the government about participating in CEPI, trying to work in COVAX, as early as this started. However, because of the multiple changes of authorities, and because of the lack of real clear channels for negotiation, nothing was going on. It was the Ministry of External Affairs, actually in Peru, who first understood what CEPI could give us and what COVAX could help us. And actually, through the Ministry of External Affairs, these issues of negotiations with vaccines started. We proposed 3 ways to start the negotiations with vaccines. One was, let's try to be part of COVAX. The second was, hey, let's try to promote through the government, participate in clinical trials for vaccines. And the third one was these bilateral negotiations. However, again, I have to insist that the change of ministers, 9 ministers, and just during the pandemic, there were 5 different ministers of health, okay? It was impossible really to move along. In September, the ministry finally released some regulations about how they implement, we needed so many regulations in order to start thinking about new vaccines. There were no ways in the country to be able to purchase anything in advance. So that's not part of our regulations or laws. And a law that was asked to be accepted at the level of the Congress took until December to get their approval. So negotiations had been very slow. And somebody was asking why the negotiations were slow. Well, one of the things is that we're a very small market, so we don't have very much power for negotiations. The negotiations that started with Pfizer, for example, apparently, the problem is that this has been very hidden within the government. There were some clauses in the contracts that were going against Peruvian sovereignty. I don't know exactly what it means, but the thing is that they were very difficult to go for. So finally, just in January, the government, the very brand new government, has been able to sign the first agreement. And actually, this is with the Chinese company, with Sinopharm, which is the vaccine for which we are doing a vaccine trial, a vaccine trial in Peru with 12,000 volunteers. And the second thing that apparently will come will be the AstraZeneca vaccines. The first 1 million doses in Peru supposedly will be arriving at the end of this month. We already have an idea of the prioritization, which will start vaccinating health providers and then going into policy, policemen and army, because we need to, we have had lots of trouble and riots and movements in the country. So just to be sure that we can have a very organized vaccination, and eventually it will move into vulnerable populations. But it has been quite difficult because of the political instability, again, not because of the lack of funds, because of the lack of channels to be able to purchase in advance, the lack of understanding from the different authorities that were changing about the need of making this type of negotiations even before the vaccines were available. And also it has been a very difficult situation.
Great, thank you. It's a very helpful perspective, and I think a common set of themes already starting to emerge around the value of governance and stability, as we've seen around the world, as well as the market power and ability to negotiate. With that, let's take a look at what's happening in India, especially at a subnational or state level. And it's my pleasure to bring into this conversation Dr. Rajeev Sathanandan, who previously served as the additional Chief Secretary in Kerala and currently serves as an advisor to the Chief Minister of Kerala on COVID management, in addition to serving as the CEO of the Health Systems Transformation Platforms. So Rajeev, thank you very much for joining us, and tell us a bit about what's happening on the ground there.
Thank you, Krishna. And good morning, good afternoon to all who are joining us here. The contrast to Peru is a good point to start from. We don't have political instability. It's been a highly centralized response of a topic that is decentralized. But unlike Peru, we're short of money. Now, as you know, India has a huge manufacturing capacity for vaccines, and the central government plans to leverage that. India has already licensed 2 vaccines, the Covishield, which is the Oxford vaccine, the AZD122222, and the Covaxin, which is Indian-made vaccine. Only one of them has completed the phase 3 trials. India is reported to have pre-ordered around 500 million units. The problem is that in the report that was presented before, we saw the numbers that India, the actual numbers that India had ordered. But when you look at per capita, even this 500 million units will be adequate only to vaccinate about 18% of Indians. And the central government, which is handling this negotiation, is doing it in tranches. The current tranche, we started the vaccination on the 16th of January, with the same priority as what is there in Peru, the health workers, the other frontline workers, and then the vulnerable population. And this current order is limited to 11 million from the Oxford vaccine and 5.5 million from the Indian vaccine. Currently, the order is only for about 30 million, but India has the flexibility as it has a large manufacturing facility. And currently, some of the vaccines are undergoing phase 3 trials, such as the Gamaleya Institute vaccine and the Novavax, all of which are planned to be manufactured in India. And when I talk to the authorities, they are fairly confident that going forward, then the supply of could really go up during 2021. The other big advantage that India has is that India has a large childhood immunization program, and this entire vaccination program is riding on the child vaccination storage and distribution system. Right now, the numbers are very low, and therefore the load on the system is will be very low. Substantial investments have been done to augment the cold chain network. Where I work, we estimated the enhancement of capacity, which is 46%, and the load is just not nowhere near this. But going forward, when additional vaccines are available, the cold chain system might get challenged. But given the kind of depth that India's vaccination program has, I don't anticipate this to be a problem, especially when the drain out is also going to be equally strong. The initial plan was to make COVID vaccination run on the childhood immunization platform. This would have caused many problems. Fortunately, at least the delivery point, this has been changed, and this could be an advantage as well as a disadvantage. We do not need the ultra cold storage because the price of Pfizer is too expensive for the public health system to procure. AstraZeneca, the Oxford vaccine needs only 2 to 8 degrees, which Indian immunization degrees Celsius, which Indian immunization system is capable of handling, even up to the most remote area. Neither will there be a problem of auto-disabled syringes or other instruments, because these are something the system can handle and has done in the past when handling campaigns like the measles rubella campaign that we ran 3 years ago. But the real problem is going to be financing. Currently, the vaccine costs government only $3, but even at that price, the financial commitment required to vaccinate the required numbers is going to be huge. Ideally, vaccination is a public good and should be funded by government. But the cost of vaccinating even 50% of the Indian population will cost 42% of the budget. If the desired limit of 70% is required, we will need 58% of the budget. It is 3 times the budget of the current childhood immunization. Unless this amount is budgeted additionally, it could eat the allocation for other health programs, which is not a good thing for a country like India, because unlike many of the developed countries, COVID is not the only communicable disease we are dealing with. There are other diseases that we have to plan for. But more than 60% of healthcare in India is privately financed and provided. Once a vaccine is available in the market, and India has the laws that can that can regulate the price, so more than 60% of the persons who are willing to take will be willing to pay for it. For others, for the people who cannot pay, there are targeted programs for means-tested targeted programs, which can be used to ensure that poor people get the needed vaccine. The process is highly centralized. As I told before, health is a state subject. But in this whole management of COVID, it's been highly federalized. Every registration, allocation of eligible persons to centers are all highly controlled. Software was used, but software glitches have been reported. And right now, decision-making powers are getting decentralized to local managers. We had expected high levels of vaccine hesitancy. However, the initial response to, like where I am, it is a Covishield, the Oxford vaccine, the Covishield, which is being reported. There has been very, little resistance, and adverse events have also been large. And what we expected was the campaign attacking the untested technology would get some traction. Even that does not work. So as of now, the vaccine hesitancy in the health workers is doing well. We are just doing health workers now. This may change when the vaccine is made available to the non-health people. The anti-vaccination lobby, which is quite strong, could come up with half truths, but government is used to dealing with it. We'll see how it works out as going forward, because we might also see adverse events, high-profile adverse events coming up, and this is an area where governments traditionally do not have much of a strength, countering information on social media. But this will be a challenge going forward, and we also expect the civil society to ramp up their effort to counter such areas. But one important thing to do is to place a robust system in place to pick up adverse events from immunization. This must be, because nowhere has a phase 4 trial been more important than with these vaccines, which have been authorized for emergency authorization. If this is not done, misinformation campaign is likely to use such events to generate hostility to the vaccine, and we might even miss a serious consequence of the vaccine because we don't have adequate experience of the vaccine. The problem is that the adverse events following immunization of adults is not something that our system is equipped to pick up, and we need to create a system for active search of the AEFI, adverse events following immunization, using some new techniques. In view of the low amount of vaccines available, it is unlikely that adequate number of people will be vaccinated to provide herd immunity that can make a difference in dynamics of the epidemic before the start of 2022. I'm discounting herd immunity because we do not have accurate measurements of how much that is. The time frame, of course, will be affected if other vaccines are added. But the danger is, as one of the virologists remarked the other day, the danger is that the darkest hour is the one just before dawn. And the mere availability of vaccine, whether a significant coverage is achieved or not, is likely to create a false sense of security, which could be disastrous for the control of spread of infections. Currently, all discussions are being tempered by the caution that mere start of vaccination is not going to be a difference. Nothing has changed in the spread of the epidemic, and we have to continue with all the non-pharmacological interventions that we have been following till now. We're hoping that will have some bit of traction, and as the effect of the vaccines kind of phase in over time, we will see a substantial decline in the incidence of COVID in India. Thank you.
Great, thank you so much, Rajiv. I think very interesting perspective, some commonalities and some differences certainly in terms of population numbers that you're looking at, the availability of financing, as well as the health system's ability, and great points also about the need to ensure that we're working on hesitancy, which, as Dennis mentioned, will be the topic of our second deep dive in February. I want to keep us moving and bring in Dr. Ahmed Agwal Oma, who's the Deputy Director of the Africa CDC. And we've heard about what's happening at a subnational level in India, the role of the national government in response in Peru. And in addition to understanding what's happening in Africa, we'll also get more of the regional perspective of Africa CDC, a young but very impactful organization already. So Dr. Agwal, thank you very much for joining us, and the floor is yours.
Thanks, Krishna, and to Duke University for inviting our participation in this webinar. Now, let me start by saying that the evolution of the COVID-19 pandemic on the continent of Africa has been distinctly different from a lot of what had been predicted before. There are many explanations for that. I think the key factors that have led to the numbers being as low as you see them is really because we, as Africa Union, Africa CDC, have brought in a level of coordination that was not there before on the continent in as far as action by the various member states are concerned, and harmonizing guidelines and things like that. So the numbers are a result of some real action that has taken place on the continent, and we are quite pleased with ourselves that we were favored to be part of this very unprecedented period in the history of Africa. As of today, we have just over 3.3 million and have registered just over 79,000 deaths. And we are seeing the whole continent now is on its second wave when we take the continent as a whole. But as you know, Africa is very diverse, and some countries are actually controlling the numbers better than others. But continentally, we are seeing ourselves in the second wave. Vaccination, really, not just vaccines, but vaccination is going to be a very important tool in bringing back some sense of normalcy to the whole globe. And that is why for us at Africa CDC and the Africa Union, there is really no option but equitable distribution of vaccines. If we don't do that, then the virus will never go away. Because the virus does not respect borders, neither does it respect a position in society and which part of the world someone comes from. So equitable distribution of vaccines is an absolute must if we are going to get a good grip of this pandemic. So for us, it makes absolutely no sense for a very healthy, relatively young individual in one part of the world to be getting vaccinated, while a health worker in the front lines in another part of the world is not getting vaccinated. This sort of a skewed arrangement will not be good for public health and will certainly open us up to even more spread of this virus in the future. So as Africa CDC, what we have done, as had been shown by Andrea in her slide earlier, is so far we have secured 270 million doses of vaccines from Pfizer, 50 million, from AstraZeneca, through the Serum Institute in India, 100 million, and Johnson & Johnson, as we await the final results of the phase 3 data, another 120 million. And all these are to be delivered during this year, 2020. We are focusing on getting our health workers to be vaccinated first before we go on to other parts of the population. Our approach is really simple, that Africa needs to go into this together. We are 1.3 billion, and in peace times, probably the largest consumer of vaccines globally. So we are going into this as a block so that we can be able to ensure that Africa's vaccination is really going in a manner that protects the most vulnerable first, and the whole continent is doing the same thing at the same time. Secondly is we are keenly involved in clinical trials, and we are in conversations with manufacturers to ensure that we have clinical trial sites on the continent, and we are participating in vaccine development. Because it's the only way to make it a lot easier for not just access to data, but also giving confidence to the African population that this is not something that is foreign. We have been part of it. Finally, as my time is almost up, is to say that the most critical part of this whole vaccine discussion is the vaccination piece, because you need to ensure that the vaccines actually reach the communities who need the vaccine. And although we keep on giving figures of how much a dose of vaccine costs, there is the costs of the syringes, the needles, documentation, the swabs, the training, indeed the cold chain, maintaining of the cold chain from the time it lands in a country all the way to the time that it goes to the facility where the vaccination is being done. These costs must be part of the conversation. These must also be part of the planning. And as Africa CDC, we are really working with our member states here to develop plans that accommodate not just the vaccine, but also the whole vaccination accessories that are required. And we are quite confident that within the end of the first quarter, most of the countries on the continent will be actually ready to vaccinate. We are also not afraid of the super cold refrigeration vaccine candidates because we have a plan for those as well. And we know exactly where we will be able to take them when they land in a country. So we intend for those to be used within the capital cities where most of the numbers are anyway, and we already have a super cold refrigerators in most of the capitals. And then those that are more amenable to higher temperatures, those are then going to go out to the communities in the rest of the country. So in summary, Africa is doing this in solidarity. We are doing it together. Second is Africa CDC is doing a lot of the coordination and including negotiations with the manufacturers. And finally is a decision that has been made by African countries is that vaccines are going to be free of charge as a public good. And our governments are finding ways of ensuring that those resources are actually accessed, not just from their own budgets, but also from COVAX. And we are also putting together financial instruments through a local institution like the Afrexim Bank and the Africa Development Bank, including the World Bank, so that funding is accessible and then the vaccines can be able to come onto the continent at the earliest possible time. So this is, in summary, what the perspective of the vaccine equity issue is on the African continent. Thank you.
Great, thank you so much, Dr. Agwal. Fantastic to hear about the amazing work that's happened across the continent and the value of a strong organization like Africa CDC in pulling the response together. I hope we'll have a chance to dive into a bit more some of the tension between COVAX versus some bilateral deals also supporting principles of equity. So I think certainly nobody would argue with the type of purchases you're making on behalf of your member states. And at the same time, we're trying to channel more purchases through and distribution through COVAX as well. So I think complex issues to come back to, but thank you for that perspective and for the fantastic work that's happening. One last country or regional perspective we want to bring into this, and I want to bring my colleague Xianglen Tang, who is our Deputy Director of the Duke Global Health Institute and has deep expertise in the response in China. And we just saw this week that China is the only major economy in the world that showed positive economic growth in 2020. So Xianglen, let me ask you, as you've heard about some of these various perspectives, how does that align and differ with what you've seen and what's happening in China?
Thank you, Krishna. I just want to be very brief because of time constraints. Overall speaking, China has effectively controlled the pandemic of COVID-19, as you know that over the last 7-8 months. Also, there have been in recent weeks a few hundred of new cases in different cities or provinces from different parts of China. But in terms of vaccinations, by the end of last week, China has vaccinated over 10 million populations, but less than 1% of the Chinese population. But it has speed up in the pace of vaccination these days, as I understand. What I want to tell us is the policy on vaccination, the prioritization of the population in China are slightly different from what we have seen in the United States, UK, other countries, or what the WHO has suggested. China has targeted the group of population with potentially high risk, such as the health workers working the front line, people working the transportation, public transportation, such as airports, railway stations, people working the services who got to integrate with many peoples. Also, China wants to target those people who are going to overseas, to studies, to work. That means China at this moment not targeting the ones who are most vulnerable to the COVID-19 infection. That said, China has not yet started to vaccinate the elder people over 60 years old, nor those young people under 18 years old. One reason is probably that 3 improved vaccine in China, China-made vaccine has not got robust data on safety, probably, for the elder people or the young people. In addition, the incidence rates of the COVID-19 is very lower in China at the moment. So there is no hurry to mess in the vaccinations, as we understand. Equity in access to COVID-19 vaccine in China got to be a greater challenge. And 2 weeks ago, the Vice Minister of Health, now in China called National Health Commission, made an announcement that the Chinese people should receive a free vaccine. But he promised they will use the money from government budget and the National Health Insurance Fund to cover these vaccinations. However, there are no detailed policies or guidelines that have been developed to indicate how much money from the national government or provincial or local government, how much money comes from the National Health Insurance Fund. So what I have heard, people from different parts of China actually are not sure how they purchase the vaccines, how to organize the campaigns of vaccinations at the moment, because there are lack of detailed guidelines. So with the support from the Gates Foundation, we at the Duke Global Health Institute has collaborated with the Chinese CDC, Zhejiang University to develop a plan on COVID-19 vaccine distribution in China, with our policy recommendations, financing, organization of vaccinations, in terms of how we, step up in prioritizing the peoples, strengthening services provision capacities, educating the public to mitigate the vaccine hesitancy, for example, and also how we should establish effective system of monitoring, evaluation of adverse effect of the vaccinations. And finally, I also want to point out or mention that China also faces dilemmas. That is, given the limited manufacture capacities this year, China also need not only to produce, to meet the domestic needs of the vaccine, but also meet demand from many countries. As now we have heard, Peru have purchased the vaccine from Chinese manufacturer companies. Also, Africa's. There are many actually countries have already proved the use of Chinese-made vaccines, such as Indonesia, Brazil, United Arab Emirates. So these countries purchasing large quantity of vaccine in China. Also, China has been part of COVAX which means they have obligations to support the other countries, particularly in Africa and the low-income countries. So we as a part of the vaccine diplomacies in China. So huge challenges. So I stop here because of time. Thank you, Krishna.
Thank you, Shenglan. That was fascinating to understand the response in such a large population and largely controlled without vaccinations being required to date. Hopefully we'll come back to the role of China and diplomacy, as you noted, in the vaccines and making them available to other countries as well, including even a note from the WHO DG yesterday asking countries to largely rely on vaccines that have gone through a stringent regulatory review, either through the WHO and its relatively new EUL process or one of the stringent regulatory authorities around the world. And so the data we're getting on the Chinese vaccines is not necessarily as transparent as we've seen from some of the others. So I think that's a fascinating topic to come back to. So for our last perspective, before we dive into some quick questions, I want to bring in Gavin Yamey, who's the Associate Director of Policy of the Global Health Institute, as well as the Director of the Center for Policy Impact in Global Health. And Gavin, you've worked closely as an advisor to many global institutions. You are working deeply at the country and regional and subnational levels. Help us put all these pieces together. We're hearing about some of the challenges in getting the vaccine and paying for the vaccine and getting going from vaccines to vaccinations. What's the role of some of these multilateral organizations? I haven't seen a huge reliance on COVAX from any of our speakers to date about the only way that they're relying on for their own needs in low and middle income countries. So what's your take on what's happening?
Thank you, Krishna. I mean, I think that's absolutely right. Where is COVAX in all of this? I mean, let me just say to Dr. Garcia, Dr. Sadananda, and Dr. Ogwell, Dr. Tang, what your countries and regions are doing is just remarkable public health leadership. Congratulations. I wish the story was a better story, right? This should be a story of pursuing global vaccine herd immunity for public health gains, economic gains, justice. And also, I mean, it's become a cliche, but it's true that an outbreak anywhere can become an outbreak everywhere. So rich nations should be focusing on global vaccine herd immunity, in part for their own good. Let me just say a few things. Back in 2009, during H1N1, in that pandemic, rich nations hoarded the vaccine through these bilateral vaccine purchases. There were so many pages and pages of editorials written saying, this shall never happen again. This will never happen again. We will put a system in place. And COVAX, and I was involved in the early design of COVAX, COVAX was an attempt to try and prevent that kind of hoarding. COVAX works in two ways. One, that low-income countries and lower middle-income countries get vaccines purchased for them. If you're an upper middle-income country or a high-income country, you are supposed to, if you join COVAX, buy doses through COVAX. And the more that you buy, up to 50% of your population covered through COVAX, the better for the world, because you're putting money up front, you're subsidizing poor nations in their delivery, and you're helping manufacturing at risk. Unfortunately, as you heard from Andrea Taylor's presentation earlier, that hasn't really worked out as we had hoped. What we really want, and what I have written about recently, is for all health workers and high-risk populations in every nation to be vaccinated first. I mean, I wrote an editorial recently arguing that actually in the US, that's what we should do. We should vaccinate that proportion of the population, pause, make sure that those similar groups worldwide are getting doses, including US doses, and then when that 15% of the whole world or so are protected, and then carry on. I get that. That is not going to happen because of, nationalistic interest. But that was the plan from COVAX all along. So the last thing I will say is we shouldn't give up and just say, well, it's a free for all. It's a wild west. Rich nations are going to, do what rich nations are going to do. I've been working with David McAdams at the business school here at Duke on using game theory to try and think through ways in which these bilateral deals could be win-win. You can't really stop these bilateral deals, but they could be configured in ways that are good for COVAX and good for the world. Dr. Tedros yesterday called on more transparency about those bilateral deals, volume, pricing, supply. We need that. But those bilateral deals could be set up in ways that benefit the world by sharing the manufacturing, by sharing the IP, by sharing doses. You know, why can't companies and high-income countries that have gone into the deal say, we're going to donate a portion of these doses to COVAX? The other thing that countries should be doing, rich countries should be doing, is they should not be jumping the queue and going around COVAX. That is a huge problem. Many of these rich nations said, we're in this. This is about global equity. They've said all the right things. They've joined COVAX, but when push has come to shove, they've actually gone around COVAX and entered these bilateral deals themselves. They need to not jump the queue. They need to buy doses through COVAX because that benefits everybody. And then lastly, and somebody already raised this in the Q&A, we're seeing very little action on CTAP. This is the WHO's COVID-19 technology access pool. You know, the companies could be sharing the know-how, sharing the IP, globalizing the manufacturing, and there should be a lot more action around that. Thanks, Krishna.
Thank you, Gavin, for putting all these pieces together, especially some of the more aspirational goals that we had as a global community. I would like to open it up. Thank you for all of the questions that we've gotten so far. Many of them you'll see have been answered in writing. We'll try to, over the next 6 to 8 minutes, get to as many as possible. So I'll ask all of our panelists to keep their answers as brief as possible. But what I'd like to start with is building from that, from the perspectives of your regions, your countries, your subnational thinking, you know, what is the best role COVAX could play? What would you like to see from COVAX, understanding what it's done to date and what the potential might be? So anybody that wants to dive into that, what's worked well? What are the challenges? What would you like to see happen in terms of a more robust multilateral response? Yes, Dr. Ogwell.
Yeah, I think for me, 3 things are very key that COVAX must really do. One is to keep the costs affordable for those vaccine candidates that will be coming into the COVAX facility. 2 is to ensure that the distribution is actually equitable. And 3 is to mobilize its network so that vaccination can be able to happen, not just to focus on the vaccine, but to also ensure that vaccination can be able to happen. These are the 3 things that I will ask COVAX to focus on.
Fantastic, thank you.
I will add one.
Please.
I will add one more, which I think we're talking in the utopic world, right? We need timely distribution of vaccines. And I think that is what has pushed some countries that are even in COVAX, like small countries like mine, to try to make some deals, because there is a lot of pressure all around.
Yeah.
We must also remember the background, the business model that was made for COVAX. What was said was that at that point when COVAX was conceived, it is not sure how many winners there would be. And what rich countries are told is that we are providing insurance for 20% of your need. Unfortunately, because these countries also led on the testing and also had access to the trial data much earlier, that incentive was taken off. And given what we've seen with the leading, and of course the Operation Warp Speed, which was set up by the US government, kind of twisted things around with prior commitments, and COVAX frankly didn't stand a chance to the extent to which it was there. And unfortunately, it got combined with a lot of other politics too. And I think the whole situation has got extremely muddy. But it just started. More, we expect Johnson & Johnson and the Novavax to be available in the next 2 months. The phase 3 of many of the others are going to be there. And we're going to see an increased supply, and we'll have better data on the Indian vaccine, the 2 Chinese vaccines, the Russian vaccine. So as the numbers become larger, and as the production facility goes up, I think the dynamics might change. It's too early to write off COVAX. We need to see how the situation is extremely dynamic and will keep changing as we go on.
Great. Thank you all for those fantastic perspectives. One more round of maybe quick responses back to the not just the Chinese vaccines, but we're seeing many vaccines either starting sales without data being available, or even starting vaccinations without full data being transparent or available. How are you all thinking of, how would you make decisions as policymakers about which vaccines to go with, or have you made some of those decisions, recognizing that there are, last I checked, 14 that have begun the process for emergency use listing from WHO, only one that has received it, which is the Pfizer-BioNTech vaccine, and the next earliest is likely to be in March. And we know that the vaccinations are happening now without that level of data, and only two, the Pfizer-BioNTech and the Moderna vaccines, have really gone through an SRA review otherwise. So how should countries be thinking about that?
Maybe I started. For us, it's really simple that we must use science to be able to make these decisions, because any slight mistake will take us years back in as far as vaccine acceptance is concerned. So we must use science. Meanwhile, we still have a whole array of tools in terms of public health measures that we can still be able to put into play as we ensure that what is coming out in terms of data is solid and is going to reflect exactly the same when we start vaccinating populations in large numbers. We must use science. The evidence has to be good before we can be able to roll out. That's our position.
Great. Yes.
So I have to say that the situation in Africa is completely different from the situation in Latin America. I always envy the fact that you have been able to organize yourself so well as a region with your African CDC, et cetera, and you have been able probably to have a much better response than Latin America, but actually we're suffering a crisis. And in the middle of a crisis, you have people desperate, you have political issues, et cetera. So in Peru, for example, number one, I think the pre-qualification from WHO, it's a great alternative, but it has to happen much faster. I hope that is not as it has been, for example, as we know in the history for diagnostics, which takes forever. So that's one of the first things. I think they have to work on the timely review of whatever data is available. Why the country has decided for the Chinese vaccine that has, that for most of the countries, the data is not open because the data has been open for us. Plus, we do have data that is coming from clinical trials that have been done in our own country. What I know is that there is data or files. I think they have filed already the data to WHO. So hopefully, in the meantime, while we wait for the vaccines, that should be analyzed there too. But I completely agree with the need science, but there are also other issues that had to be taken into consideration, which it's the critical issue at this point. Even with vaccines like, the other vaccines like Pfizer, it's not an alternative for countries like ours with those issues of asking for ultra freezers. I hope that pretty soon we will start seeing other vaccines that will come with more data, that will be more, that could be used in the situations or for the access that we need as an emergency. We are living an emergency. Probably it's going to be hard to start waiting longer for something to happen, especially when you see the other countries, like high income countries, are already showing you how they are vaccinating, and in your country, nobody's receiving anything.
Yeah, thank you all.
I think we need to understand can I?
Yeah, please.
Okay. We need to understand the difference in perspective from where the scientists come from and where the policymakers come from. I'll refer to a paper, I think it came out of the Yale School of Public Health, which is looking at how a vaccine that is even less than 50% efficacious could be preferred by a policymaker when you define the effectiveness of vaccination as controlling the epidemic versus preventing mortality. Now, for an individual, yes, preventing mortality is the ultimate. But for a policymaker, preventing the infection is a more important thing. So Sinovac, which Brazil recently certified has around 50% efficiency, is good enough from the policymakers' point of view. Of course, it has problems in the sense that when you've already started experimental use, how do you confirm efficacy? All you can do is effectiveness, and since efficacy is a necessary condition for effectiveness, we have to presume that this is what will work. But the perception from the scientists and the policymakers is something that we need to factor in. And WHO needs to move fast. I fully agree with that.
Great, thank you all. This is a topic that is not only timely, but one with such complexity we could keep going. Unfortunately, we are at time. I want to thank profoundly all of the speakers who joined us from around the world today to share your experience, your expertise. Thank you for joining us. Thank you also for the amazing work you're doing and contributing to the local and regional and global response. Thank you also to our leadership at the Global Health Institute for making this happen. I will remind you that the next of these sessions is going to occur February 23rd at the same time, 8 a.m. Eastern time, with a focus and deep dive into vaccine hesitancy and acceptance. So thank you all. We will follow up with the link to the recording, as well as some answers to some of the questions that we couldn't get to so far. Good morning, good afternoon, and good night to everyone.
Thanks very much, Krishna and the panelists. Much appreciated.
Thank you so much.
Thank you.
Thank you all.